Thyroid disease in pregnancy. This is the functional anatomy of the thyroid gland. As you all know from your physiology, that the hypothalamus releases the thyroid releasing hormone, which acts on the pituitary gland, and the pituitary gland releases thyroid stimulating hormone, which acts on thyroid gland, and it releases T4. Then there is peripheral conversion of T4 to T3, and the most of the 75% of the thyroid hormone that is produced from the thyroid gland, then it gets bind with the thyroid binding globulin in the liver, and only small amount of the thyroid hormone remains in the free form, that is metabolically active form. So, the thyroid disease is more than occurs in more than 1% of the population. It is the most common pre-existing disorder in pregnancy, and the pulsatile release of TSH is every 1 to 2 hourly from the pituitary gland. And as I said, that 75% of the thyroid hormone that is produced is bound to the thyroid binding globulin. The rest, and very few amount, is unbound, that is biologically active form, and that produces the effects in the body. Only 0.04% T4 and 0.05% of T3 is free. Rest all is in the bound form. Iodide is an essential component for the synthesis of thyroid hormone. Therefore, whenever there is deficiency of iodine or iodide in the body, again it will affect the thyroid hormone levels. There are few physiological changes that occur during pregnancy. There is increase in the total T4 and T3 levels, but there is concurrent increase in the thyroid binding globulins due to the reduced hepatic clearance and estrogenic stimulation. And as the T3, T4 levels and thyroid binding globulins are both increasing, so the free circulating levels of T4 and T3 are same. So it means that the biologically active thyroid, that is free T3 and T4, is same, but the total T4 and T3 increases along with the thyroid binding globulin. As the level increases, the more will bind to the thyroid binding globulin, and the free levels, free T3, T4, will remain the same. The thyroid binding globulin increases 3 times and reach a plateau till the 20 weeks. Plasma iodide levels, they decrease due to the fetal iodide use and increase maternal clearance. So it leads to the notable increase in gland size in 15% of the women during pregnancy. But we generally don't treat these women because it becomes to the normal level after the delivery. So uh, this is the fetal thyroid function, that before 12 weeks of pregnancy, the fetus is utilizing the maternal thyroid hormone for the brain development. But from 10 weeks, the fetal thyroid gland starts producing T4 and T3. And after 12 weeks of pregnancy, the only thing that the fetus requires is the iodine. So there is transplacental transportation of number one, iodine, and thyroid releasing hormone, and the fetal thyroid will start producing its own thyroid hormone. That is the reason that after 12 weeks, the maternal iodine level is transported through placenta to the fetus. So there is decrease in the maternal circulation, and as we discussed, that there is a slight increase in the thyroid gland level in most of the mothers. The fetal levels that reach the adult levels by 36 weeks of gestation, and fetal thyroid stimulating hormone level is more than the maternal levels. T3 is lower as a result of little peripheral conversion and a good placental barrier. Both thyroid releasing hormone and the iodine, they freely cross the placenta. These are the physiological changes in the thyroid function during pregnancy. As we said, that in pregnancy there is no change in the thyroid stimulating hormone, there is no change in the free T3, T4 levels. However, the total T3 and T4 will increase. In hyperthyroidism, there is decrease in the thyroid stimulating hormone, while there is increase in T3, T4 levels, and similarly, there is increase in the total T3, T4 levels. In hypothyroidism, there is increase in the thyroid stimulating hormone, while there is decrease in free T3 T4 levels, and the total T3 T4 levels will also decrease. So first we will discuss hyperthyroidism in pregnancy. It occurs in 1 in 500 pregnancies. Untreated thyrotoxicosis is associated with reduced fertility. Generally, patients with either hyper or hypothyroidism are unable to conceive once their thyroid levels are deranged. They only conceive if we optimize before treating them for the pregnancy. So, most of the time, once the patient becomes pregnant, the levels are normal. But in cases of untreated thyrotoxicosis, if the woman um, conceive, then only it requires the continuation of the treatment, and we should look for the signs symptoms during pregnancy. Usually, the autoimmune thyrotoxicosis is Graves' disease, and less than 5% results from the toxic nodule or thyroiditis or carcinoma. If a pregnant woman presents with hyperthyroidism, then the as we all know that the beta subunit alpha subunit of beta hcg and tsh is same. So if the patient is having hyper msas or molar pregnancy in which the levels of beta hcg will increase, there is also concurrent increase in the thyroid levels, patient can have hyperthyroidism. But generally these patients are not given any treatment, and we just follow. Once the level of beta hcg decreases, then the level becomes normal. Disease activity and severity are correlated to immunoglobulins, thyrotropin, TSH receptor antibodies. Autoimmune thyroiditis, all type of autoimmune disease, either it is thyroid disease, either it is uh, any type of SLE or whatever, the all autoimmune diseases, they generally remit in the last two trimesters, second and third trimester, and flares are commonly seen in the postpartum period. So it is very important to start the patient immediately on medication immediately after delivery. These are the signs symptoms of hyperthyroidism. We should look for nervousness, tremors, tachycardia, frequent stool, sweating, heat intolerance, weight loss, goiter, insomnia, palpitations, hypertension, lid lag or lid retraction or pretibial myxedema. And investigation levels are serum TSH, free T3, T4 levels. Then TSH receptor stimulating antibodies. First, we go for thyroid stimulating TSH levels. If TSH levels are deranged, then we go for free T3, T4 levels. If they are still deranged, then we go for the thyroid stimulating hormone antibodies to rule out the autoimmune disease. Treatment. The goal of treatment is to maintain the euthyroid state in pregnancy. We measure free T3 T4 levels 4 to 6 weeks and titrate the treatment or the disease dose of the medications according to the levels. The most common drugs are thioamides. These are propylthiouracil or methimazole, and they basically decrease the thyroid hormone synthesis by blocking the incorporation of iodide in tyrosine. As we discussed earlier, that iodine is the main component of the thyroid hormone synthesis. So they block the incorporation of iodide and, and inhibit the production of the thyroid hormone. Previously, in previous studies, the propylthiouracil was traditionally preferred drug because of the less side effect profile. But current and the methimazole or carbimazole was considered to be associated with the fetal alopecia cutis. But nowadays, we give the preference that whatever the drug patient is already taking should continue during pregnancy rather than switching to the other drug. And we just follow with the levels of the thyroid hormone. Beta blockers are also used just for the symptomatic relief of the palpitations. And if the patient is not responsive to the medical treatment, then we go for the thyroidectomy. But and the other third line treatment is the radioactive thyroid ablation with iodine 131, but it is contraindicated during pregnancy because it can lead to fetal thyroid ablation also. And if the patient is already if the patient is taking some medication, we will continue with the medication, and if patient requires this radioactive ablation, we will go after delivery. And after delivery, we will ask the patient to avoid pregnancy for next 4 to 6 months, and she should not do breastfeeding if the radioactive ablation is done in the immediate postpartum period. Breastfeeding is safe if the patient is only taking propylthiouracil or carbimazole. These side effects are the problems that are associated with hyperthyroidism in pregnancy are preterm delivery, low birth weight, fetal loss, thyroid storm, fetal thyrotoxicosis can occur that is related to disease itself or treatment, risk of immune mediated hyperthyroidism due to because the antibodies they can cross the placenta, and antibodies in grave disease can either be stimulatory or inhibitory. Therefore, the fetus can have either hyperthyroidism or fetus can, even if mother is hyperthyroid, the fetus can be hypothyroidism also. Neonates of women with Graves' disease who have been surgically or radioactively treated are at high risk of hypothyroidism because of the fetal thyroid ablation. Both PTU and carbimazole they cross the placenta and make fetus hypothyroid, but it does not affect the neurodevelopmental status of the fetus. Goiters are generally small and they resolve in 2 weeks' time. No long-term fetal effects of antithyroid drugs have been reported yet. Both drugs are expressed in breast milk, but they have very little effect. Therefore, breastfeeding is not contraindicated. Now, coming to the hypothyroidism, as we all have seen this chart before, that in hypothyroidism, there is increase in the TSH level and decrease in free T3, T4 level during pregnancy. It occurs in 1% of the pregnant women, usually due to autoimmune Hashimoto's thyroiditis, can occur following treatment of hyperthyroidism that can progress to myxedema and coma. Subclinical hypothyroidism with elevated TSH, normal free thyroid index is in asymptomatic patient. It is associated with other autoimmune disorders like patients can have type 1 diabetes, 5 to 8% risk of patients with type 1 diabetes. They are having 5 to 8% risk of hypothyroidism, and 25% postpartum thyroid dysfunctions are associated. Symptoms are fatigue, constipation, cold intolerance, muscle cramps, hair loss, dry skin, slow reflexes, weight gain, intellectual slowness, voice changes, insomnia, and carpal tunnel syndrome. The fetal and neonatal effects are that there is higher incidence of low birth weight due to medically indicated preterm deliveries, preeclampsia, and abruption. Iodine deficient hypothyroidism leads to congenital cretinism, which leads to growth failure, mental retardation, and neuropsychological deficit. There is reduced IQ in babies of the women with the profound hypothyroidism. The causes of the hypothyroidism can be either autoimmune, that is Hashimoto's thyroiditis, subacute thyroiditis, thyroidectomy, radioactive iodine treatment, or iodine deficiency in the woman. That is the most common worldwide cause. That is the reason the iodized supplementation was iodine supplementation of the salt was started to reduce the risk of hypothyroidism worldwide. Treatment of hypothyroidism is that preconception optimization is mandatory, as mostly insult occurs during first trimester, and if there is hypothyroidism, these women are again treated with the levothyroxine in sufficient doses. We repeat the thyroid TSH levels after every 4 weeks and adjust the dose accordingly. In conclusion, that the thyroid disease in pregnancy is the most common pre-existing disorder in pregnancy. Continuation of same medication in pregnancy is advisable. Mode of delivery is according to the obstetric indication. Hyper or hypothyroidism will not affect the mode of delivery, intrapartum management, or postnatal management because of this particular disease. Epidural analgesia is again not indicated, and breastfeeding is also allowed along with the medical treatment. Now, the second disorder is asthma in pregnancy. Asthma is a common respiratory disorder that is affecting the women of the childbearing age. Chronic inflammatory, it is basically the chronic inflammatory disease of the airway, and it manifests as the hyper response to wide variety of stimuli. As we all know that asthma is basically asthma flares or it precipitates whenever there is some precipitating factor like allergens, upper respiratory tract infection, Some people are allergic to some medications like aspirin, beta blockers, environment pollutants, exercise, cold air, emotional stress. The condition is more common in atopic allergic individuals. And incidence of asthma in pregnancy is 1 to 4%. Generally, 33% of the patients with asthma they remain unchanged during pregnancy. 28% improve patients with the asthma they improve during pregnancy, and 35% worsens. Asthma is in no way be considered as a contraindication to pregnancy. The only thing is that the disease should be properly treated before the patient enters in the pregnancy to avoid any problems during pregnancy. And if the patient is taking any medication, any inhaler, medications, or steroid, we can continue during pregnancy. The most common reason that asthma symptoms deteriorate in patients reducing their treatment because of a belief that medication may be harmful. This is the most common myth in most of our patients, that the medications they cause problems during pregnancy. So most of the patients they stop taking their medications. These patients they require a thorough counseling that whatever medication they are taking should continue, and we can just follow for any side effects or any teratogenic effect of the drugs. All commonly used drugs to control asthma are safe in pregnancy, so we can confidently continue with the medications. All patients must be reassured that any flare of asthma must not be ignored, because still there is high mortality associated with the acute asthma during pregnancy. So, treatment with medications such as steroid is safe both for mother and fetus. With regard to the effects of asthma on fetal outcome, there is no evidence that there is any significant impact on the fetal growth or outcome due to asthma. Maternal and fetal risk that asthma may worsen in pregnancy due to other treatable conditions, like if the patient is having gastroesophageal reflux disease or she is having pregnancy rhinitis. These problems can precipitate the asthma. Any patient whose asthma seems to be deteriorating during third trimester should be seen by the physician, and the appropriate control of asthma should be done before she enters in the labor. So, the pregnancy counseling should be based on preceding information. Overall, it should be anticipated that pregnancy will be well tolerated. Education about proper use of medications and inhalers, and not to stop the medications during pregnancy is the mandatory part. Prenatal, ideally, asthma should be optimized before conception. Close monitoring and dose adjustment is essential. During labor, the asthma exacerbation in labor due to natural release of endogenous steroids and epinephrine. Uh, Generally, the exacerbation of the asthma during labor is rare because of the natural release of the steroids and epinephrine, because of the stress of delivery. Again, the intrapartum management is not different from a normal patient. We can safely use prostaglandins, we can safely use oxytocin, and PGF2 alpha and ergometrine should not be used because these lead to bronchospasm. This is the important component. Then, similarly, the postnatally breastfeeding is not contraindicated if the patient is optimally managed, and if she is taking any medication, we can continue and we can start the baby on the breastfeeding. The differential, like if the patient is if there is suspicion of exacerbation of asthma and labor, the other differential should also be considered. For example, pulmonary edema, it can be because of the cardiac cause or non-cardiac cause, such as preeclampsia, toccolysis or sepsis, pulmonary embolism or aspiration. And attacks of asthma during labor can be managed with the conventional treatment whatever she is taking previously. And those women who are taking some steroids for more than 2 weeks time period, they should be given a stress dose of steroid during labor, that is 10 milligrams hydrocortisone 1 bg for 3 days. And this stress dose of steroid is required for all women who are taking steroids for any reason during pregnancy for more than 2 weeks. So management options are that if the operative delivery is required, epidural analgesia is preferable than general anesthesia. If general anesthesia is required, the anesthetic care is same as the patient was not pregnant. Patient with severe asthma should be delivered in the centers where appropriate backup facility and medical expertise are available. Acute asthma is still a cause of maternal death and must be taken extremely seriously. So again, the main crux or the main take-home message is that multidisciplinary approach is required. So these patients they should be delivered in a tertiary care setup where the backup ICU facilities or the pulmonologist are available. Postnatally, the patient should continue their medications. Breastfeeding is not contraindicated even if the patient is on steroids. The breastfeeding rather reduces the risk of atopy by 30 to 50% if the if the newborn is exclusively breastfed for 6 to 12 months. Risk of child developing asthma in later life varies between 6 to 30% depending on whether only mother or both mother and father are atopic. Conclusion is that asthma should not be considered as a contraindication to pregnancy. Advice is to continue the treatment during pregnancy. Optimal control of asthma is essential prior to the onset of labor. Routine medications have no adverse effects on fetus. Exacerbation is rare in labor. Prostaglandin E2 and oxytocin can be used safely. PG2 and PGF2 alpha and ergometrine should not be used because they causes bronchospasm. Labor should be covered with hydrocortisone if mother is taking steroids for more than 2 weeks. Epidural analgesia is preferred, and breastfeeding is not contraindicated even if mother is on prednisolone. Now, coming to the third disorder, that is the epilepsy during pregnancy. Again, in epilepsy, the main thing is that whatever the medication the patient is taking before entering in the pregnancy should be continued during pregnancy, even if all the anti-epileptic drugs they have side effects, and these side effects should be explained to the female, and they should be looked for during in the anomaly scan and should be covered. But there is no recommendation to change the medication. We can only adjust the dosage of the drugs. We will discuss later on. 0.5% of the women of childbearing age have this commonest chronic neurological disorder that can complicate the pregnancy. The classification of epilepsy or seizures is same as in the other non-pregnant patients, like primary generalized epilepsy that includes the tonic-clonic seizures. Absent seizures are myoclonic jerks. Partial or focal seizures with or without loss of consciousness are secondary generalization. Are temporal lobe seizures. Pathogenesis is that idiopathic and no underlying cause is found. 30% of the females they have family history of epilepsy, previous surgery to the cerebral hemisphere, intracranial mass lesions like meningiomas or the AV malformations they enlarge during pregnancy. Are most commonly pregnancy associated cause is the antiphospholipid syndrome, in which the patient can present with the seizures even during the first and second trimester. Other causes of seizures in pregnancy are most commonly eclampsia, cerebral venous thrombosis, thrombotic thrombocytopenic purpura, stroke. Risk is increased in pregnancy, and 4% have the seizures. Subarachnoid hemorrhage. These are the causes in which the patient can present with the seizures for the first time in pregnancy. Drug and alcohol withdrawal, hypoglycemia. If the patient is diabetic and the sugars are low, patient can have the fits. Hypoadrenalism, hypopituitarism, and liver failure. All these are the causes of the seizures during pregnancy. Again, diagnosis first we have to establish the cause of the seizure during pregnancy. So, CT and MRI to rule out any brain pathology, as we discussed. We check the blood pressure because during pregnancy, the most common cause that is considered that is associated with the seizures is the eclampsia. So, eclampsia, preeclampsia are common. This commonly precipitate in those females who are having pregnancy-induced hypertension. Then urine analysis, especially to look for the proteins, uric acid, platelet count, clotting screen, and blood glucose level to rule out hypoglycemia, serum calcium for hypocalcemia, serum sodium for hyponatremia, and liver function test. Effect of pregnancy on epilepsy, that in most women, pregnancy does not affect the frequency of seizures. 50% of the females they remains unchanged. 37% have increased frequency of fits during pregnancy, and 13% will have decrease in the seizure activity during the pregnancy. There is no relation to the seizure type or course of epilepsy during previous pregnancies. 3.5% of pregnancies were complicated by the intrapartum seizures. And generally, if there is no previous history of seizures in the female and patient throws the fit during labor for the first time, so the most common diagnosis during of the intrapartum fit is the eclampsia or preeclampsia. The features that is relatively resistant to short episodes of hypoxia. Whenever the female will have a fit or seizure activity, there is a transient episode of hypoxia to the fetus. But if the mother had single seizure, so the fetus is generally resistant to these short episodes of hypoxia, and there is no evidence of adverse effect of single seizure on the fetus. But if the mother is having seizure activity repeatedly, then fetal bradycardia can occur, and after maternal tonic clonic convulsions, the cerebral damage can occur in long term, and fetal bradycardia can occur during and after maternal tonic clonic convulsion, but cerebral damage in long term is not a feature. As I said, that all the anti-epileptic drugs that are that we know have the side effects. They have major malformations associated. Most common fetal anticonvulsant syndrome that is associated with these are covered under the one umbrella of fetal anticonvulsant syndrome, and the major malformations that are associated are: number one is the neural tube defects, particularly associated with the sodium valproate and carbamazepine. 1 to 3.8% associated with the sodium valproate and 0.5% with the carbamazepine. Orofacial clefts, particularly with phenytoin, carbamazepine, and phenobarbital. Congenital heart defects, these are associated with phenytoin, phenobarbital, and valproate. Microcephaly, intrauterine growth retardation, and developmental delays are associated. Minor abnormalities that are associated are hyperthyroidism, flat nasal bridge, low set ears, and long felt tongue. So the most important thing is that if the patient is having epilepsy and she is already taking some drugs, we will not change any medication. Rather, we will adjust and to adjust the dose, and we will give them in the small doses. And these patients they require a detailed anomaly scan at 22 weeks of gestation to rule out these major problems like neural tube defects, orofacial clefts, and congenital heart defects. Similarly, vitamin K deficiency is caused by carbamazepine, phenytoin, phenobarbital that can lead to fetal hemorrhagic disease of the newborn with catastrophic intracranial and GI hemorrhage immediately after birth. So this can be prevented with vitamin K therapy. We give the 10 to 20 milligrams of oral vitamin K to the mother after 36 weeks of pregnancy for at least 4 weeks, so that the vitamin K deficiency should not be encountered immediately after birth, and we can prevent this hemorrhagic disease in the newborn. Then fetal withdrawal symptoms can also be noted in few of the drugs, like most commonly in the phenobarbital. So the management is again multidisciplinary. We should always take the neurophysician on board if the patient with epilepsy is booked in the obstetric unit. Pre-pregnancy management in established epilepsy is recommended. That patient should plan the pregnancy once she is fit free and she is maintained on the medication. So, as we discussed, that the neural tube defects are commonly seen in these patients who are taking anti-epileptic drugs, because these drugs mostly have anti-folate activity and they lead to folate deficiency in the fetus. Therefore, these women should be given 5 milligram of folic acid prior to conception, and this should be continued after conception throughout the pregnancy, as there is also small risk of folate deficiency anemia. Then there is no need to change anti-epileptic drug if the epilepsy is well controlled with phenytoin, carbamazepine, valproate, lamotrigine, and phenobarbital. This is the most important, that if the patient is maintained on some drug, we should, whatever what we should do is to reduce the peak concentration level, for which we will give the drug in the divided doses, so that uh, we can avoid the side effect profile. For example, if the woman is taking some drug in a complete dose of 600 milligrams per day, rather than giving 600 once daily or 300 twice daily, we will give them 200 milligrams three times daily, so that peak concentration levels are maintained at a lower level. The disease is controlled, but the side effect profile will be low. And however, any risk of valproate should be balanced against the risk of seizure with pregnancy whenever considering or reducing the, if the side effects of some drugs are noted, then we should always consider that what are the risks associated with stopping the drug, because patients can have fits during pregnancy and they have more severe effects on the fetus, can lead to fetal bradycardia, can lead to hypoxia. Therefore, we should rather change the dose, or we should counsel the patient that the risk associated with stopping the drug is more as compared to the continuation of the drug. Um, if we continue sodium valproate therapy, it should be changed to 3 or 4 times daily regime for our modified release preparation. As I said, that rather just to reduce the peak concentration level, we should, rather than stopping the drug, we should decrease the peak concentration level by giving in the multiple divided doses. If patient is seizure free for more than 2 years, then we can consider to stop the medications. But again, if we stop the medication, these patients should be kept under close surveillance, because she can have fits again immediately after stopping the treatment. Vitamin K 10 to 20 milligrams should be prescribed in last 4 weeks of pregnancy for women with epilepsy taking the hepatic enzyme reducing drugs. Intrapartum management, the most important thing to counsel the patient and to be known by the staff in the labor unit are that these patients should be given their treatment during labor. There is no point of stopping their treatment intrapartum, because the risk of seizure increases around the time of delivery. Women with major convulsive seizures should be delivered in the hospitals, again, well equipped with the neuro facilities, well equipped with the ICU setup, and the multidisciplinary approach should be adopted. 1 to 2% of women with epilepsy will have seizures during labor, and 1 to 2 will have one in first 24 hours postpartum. So even if the patient delivers safely, we should also keep the patient under close surveillance even in postpartum period, because patient can throw fit, and we should continue the anti-epileptic drugs in the postpartum period, even though the doses are adjusted, because the doses are generally increased during labor, and after postpartum time period, the doses will be decreased to maintain the peak concentration levels in the circulation. To limit the risk of precipitating a seizure because of pain and anxiety, early epidural analgesia should be considered during labor, because pain or anxiety can be a precipitating factor for the seizure, and there is no contraindication for epidural analgesia. If the seizures that are not rapidly self-limiting occur in labor, Oxygen and IV lorazepam or diazepam 10 to 20 milligrams or 10 to 20 milligrams intravenously should be given to sedate the patient and to reduce the anxiety and pain to avoid the precipitation of the severe activity during labor. Most women with epilepsy have normal vaginal delivery, and cesarean section is only required if there are recurrent generalized seizures in the late pregnancy or in the labor. Postnatal management, again, we should continue with the anti-epileptic drugs in postnatally. The neonate should be given vitamin K 1 milligram intramuscularly immediately after delivery to avoid the hemorrhagic disease of the newborn. All women with the epilepsy should be encouraged to breastfeed. Most anti-epileptics that are secreted into breast milk, but the dose that is received by the baby is just 3 to 5% of the fraction of therapeutic level, and in any case is less than that is received in utero. The babies whose mothers receive phenobarbital during pregnancy may experience withdrawal symptoms if they are not breastfed. High dose oral contraceptive pills and Depo-Provera are the best choice of contraception. So, if the mother remains stable postnatally, then we should give contraceptive advice so that she can continue with the anti-epileptic drugs postnatally. But these patients who are taking anti-epileptic drugs, they require higher dose of the oral contraceptive. Are the best choice is the Depo-Provera intramuscular injection every 3 monthly for the contraception, so that she can continue her anti-epileptic drugs and should enter in next pregnancy once her